Where is the question?
I don't know. Is it coming? Is it loading? I don't know.
I don't know what is happening.
Oh,
Okay, now.
where? Do you see it?
Yes, I can see it now.
Okay, your screen is still blank. Or did it froze for me? Okay, now.
Now. The 45 one.
Yeah.
Okay. You will read or I?
Uh, okay, I read.
Okay, if you want me to read, I can do it too. Okay.
Okay.
A 45-year old woman comes to the physician for a 3 week uh, for a 3 week history of intermittent episodes of dizziness. The episodes last for hours. The episode lasts for hours at a time and are characterized by the sensation that the room is spinning. The patient also reports that she has started using her cell phone with her she has started using her cell phone with her left ear because she hears better on that side. She has experienced intermittent ringing and fullness in her right ear. She has no history of serious medical conditions. She does not make, smoke, drink alcohol. She takes no medication. Her temperature is 37.1, pulse 76 per minute, respiration 18 per minute, blood pressure 130 by 70. Cardiopulmonary examination show no abnormality. There is a horizontal nystagmus to the right. There is horizontal nystagmus to the right. Motor strength is 5 by 5 in all extremity, and sensory examination shows no abnormality. Finger to nose and heel to shin testing are normal bilaterally. Weber tests show lateralization of the left ear. Rini is positive bilaterally. Rini is positive bilateral. Which of the following is most likely cause of this patient symptoms?
Can you put all the answers on the? Can you scroll down?
Yes, yes, obviously. I should make things smaller. It would be sorry.
Oh,
Is it comfortable for you
yeah.
now?
Okay. Okay, I'm ready. Got the answer.
Is it Meniere's?
Yeah.
So is it this one endolymph?
Yeah. I think.
Okay, okay, we are right. Like in here, we can show all the explanation, but uh,
Oh.
if you scroll it, we can see all the explanation. So
Mm-hmm.
you like to read all the explanation. That's why I told you.
Yeah.
Okay, and another beautiful thing in here. We will discuss it later. Okay, I don't know why I am advertising this.
I like it. It's like a improved
that
version of
that's
you.
that's why I told you to just and I that's why I have bought it, and I will try my level best to give something best. If it happens or not, it's Almighty's wish, but our
Mm-hmm.
effort should be there. Okay, I'm talking too much. Okay, reduced resorption of endolymph leads to accumulation. Reduced resorption of the endolymph leads to accumulation of the fluid in the endolymphatic sac and causes Meniere's disease. If an audiometry was performed, it would typically show low frequency hearing loss. And differentiating the Meniere's disease from other conditions that will manifest hearing loss other than other frequency range like acoustic neuroma. Okay, this is the library. Okay.
Oh.
I don't know why it is taking too much time. Maybe my internet is slow. The okay, you can click anything and you can straight go to the library. Uh,
Library. Hmm.
Yes, okay. So you want me to read the other options?
No,
Okay,
no, that one is pretty clear.
okay. If we look at this picture, okay, we don't need to be master on those pictures. Okay. A previously healthy 1 year old boy is brought to the emergency department because of irritability and fever for 2 days. His symptoms began shortly after returning from trip to the Canada. He was born at term. His immunizations are up to date. His 6-year-old brother is healthy and there is no family history of serious illness. The boy appears weak and lethargic. He is at 50 percentile height, 75 percentile weight. His temperature is 39.2 degrees Celsius. Pulse is 110 per minute. Respiration is 28 per minute and blood pressure is 92 by 55 millimeter of mercury. Physical examination shows purple spot over the trunk and the extremities that are 1 millimeter in diameter. Capillary refill is 4 seconds. The remainder of the examination shows no abnormality. His hemoglobin is 12, leukocyte is 19,000, platelet count is 2,25,000. A lumbar puncture is done. CSF analysis shows abundant segmented neutrophil, decreased glucose concentration, and increased protein concentration. Which of the following is the most appropriate step in the management?
Can I see the last answer choice?
Yes.
The- Hmm.
1 year
1 year, can they give us a triason? I know you cannot give them to babies, but 1 year, can you
can be
give them?
given.
Can be given. Okay, if it can be given, then I'm going with D as in dog.
Yes, and in here there is prophylaxis also, like rifampin as prophylaxis. You are thinking about what?
D as in dog.
Like what is your okay?
Oh, I was thinking
Bacterial meningitis, meningococcal meningitis. Yes, I got it. And
okay, so
rifampicin, yes.
ceftriaxone you cannot give
Ceftriaxone
it.
cannot be given within 28 days
Okay,
because
first one. Okay.
yes, you want to see this option. Which one?
Which one?
I will read the explanation, then you decide which option you want to see.
Okay.
Okay. So a combination of vancomycin and third generation cephalosporin like ceftriaxone and cefotaxime is used for empiric treatment of community acquired meningitis to cover the most likely pathogens in patients between 1 month and 15 years age, including Streptococcus pneumoniae, Neisseria meningitis, Haemophilus influenzae. Meningococcal meningitis has high fatality rate, and rifampin is used post-exposure prophylaxis in close contact. The mother close contact. Post-exposure prophylaxis is an important to prevent infection and to eliminate nasopharyngeal carriage for Neisseria meningitis and thus limiting disease transmission. Ceftriaxone should be avoided less than 1 month of the age because of increased risk of biliary sludging and kernicterus.
Got it.
Okay. You want me to
Okay.
read the other options?
No. It's
Okay.
clear.
So, like, look at the attendant tip. They actually summarize everything. Like,
Oh, there.
yes, high fever, irritability, CSF findings, and neutrophilic pleocytosis, suggesting that in decreased glucose, increased protein, bacterial meningitis, and petechiae makes meningococcal meningitis a likely diagnosis for post-treatment prophylaxis. Okay, next. Uh, Okay, a 27-year-old woman comes to the emergency department because of progressive numbness and weakness in her left arm. Progressive numbness and weakness in her left arm and left leg for 2 days. During this period, she has urinary urgency and incontinence. 3 months ago, she had blurry vision, difficulty distinguishing color, and headache for 1 week, all of which have since resolved. Her temperature is 37, pulse is 78, respiration 14 per minute, blood pressure 110 by 68, muscle strength in the extremities 3 by 5 on the left and 5 by 5 on the right. Upon flexion upon flexion of the neck, the patient experiences shooting electrical sensation travels down the spine. An MRI of the gadolinium enhancing right lesions in the right central sulcus, cervical, spinal cord, optic nerve. Which of the following is the most appropriate? You got the diagnosis, isn't it?
I think it's
MS.
MS.
Yes.
So C.
Yes, because it is acute condition, so we will give methylprednisolone. Okay.
Mm-hmm.
Look, this is the wonderful thing.
Mm-hmm.
Like we are seeing MRI plenty of time, but we are unable to see the lesion, isn't it?
Mm-hmm.
The lesion is in here, but it is inconclusive. Now the overlay. You got my point? They will teach you how to see the images.
Nice.
Isn't it nice?
Yeah.
And
Very
and
nice.
the another wonderful option what I have found, like
Uh-huh.
wait, I'm copying this thing.
Uh-huh.
Okay, and we can save it for tomorrow. You found it? You can,
Okay, let me
like,
see.
the uh, the MRI or something.
Mm-hmm.
We have some difficulty. So if we uh, can copy those images, and it is kept in for previous for before exam, so
Mm-hmm.
we can see these things before my need not, sorry, you need not to like re- okay, I'm sending everything.
Mm-hmm.
This is the explanation.
Mm-hmm.
Okay, so
Mm-hmm.
that's why it is wonderful. Okay, I'm advertising too much, sorry,
Ah,
but I am overwhelmed with this. That's why I am very enthusiastic to share with you. Okay, the first line management for acute MS exacerbation is high dose IV glucocorticoid. These high dose IV glucocorticoid, typically 500 to 1000, typically 500 to 1000 milligram of methylprednisolone given for 3 to 5 days. As with any patient receiving high dose glucocorticoid, a proton pump inhibitor to prevent gastritis should be concurrently, and patient should be monitored for hyperglycemia. Patient who do not respond to high dose glucocorticoid should be treated with plasmapheresis. Okay.
okay. Can you read plasmapheresis and
Yes,
interferon?
yes. So plasmapheresis is the second line for acute MS exacerbation, and it is first line treatment. Has If first line treatment has failed, or there were contraindication to it, then plasmapheresis would have been an appropriate treatment option.
And interferon beta. Can you
Yes.
read that?
Glutatimer interferon beta. Okay. Interferon beta is an immunomodulator, uh, and a first line agent for disease modifying MS therapy, which prevents not treat exacerbation. Although patient Although this patient will most likely need disease modifying therapy in the future, she first requires treatment for the acute exacerbation of her symptoms. Okay,
Okay.
you want me to read the other options?
No, that's good.
Okay, you want to see the disease modifying MS therapy?
Oh yeah, sure.
Like side by side, you can go through the library. I don't know why it is taking too much time. My internet is not that slow. Okay, okay. This is the disease modifying, like interferon
Mm-hmm.
beta, glatiramer, dimethyl fumarate, teriflunomide, and cladribine. Another is sphingolimus, this and that. Okay, plenty of drug.
Jeez, never heard the name of some of those.
Okay,
Mm-hmm.
so this is used for relapsing and remitting. These drugs like interferon therapy, glatiramer, dimethyl fumarate, teriflunomide, and sphingolimus, mitrox. Okay. And one important question from here is natalizumab. Do you know what natalizumab does?
Mm-mm.
Natalizumab has specific side effect. Okay, I forgot.
Mm.
Okay, let's go to next question. I
I
have
thought I
plenty.
thought
Sorry,
I thought you were showing that to you there. That's why you were asking me. I thought you were showing
no
that to me.
natalizumab. There is one drug of the MS cause uh, pro- PML.
Mm.
I actually
Okay.
forgot which drug.
Mhm.
Okay, this is one of the question. That's why I am interested in. Okay, a 22-year-old woman comes to the physician because of why hearing loss and unsteadiness while sitting and walking for the past 2 months. So, hearing loss and unsteadiness while sitting and walking for the past 2 months. She needs to support herself against a wall to avoid falling. She has not had any recent injuries and has no history of serious illness. Vital signs are normal. Examination shows an unsteady gait. She swallows when asked to stand upright with her feet together. She is unable to hear of fingers rubbing next to her ears or repeat words whispered in her ear. MRI of the brain shows 3 cm tumor in the right cerebellopontine angle and 4.5 cm tumor in the left cerebellopontine angle. The patient should be for counseled that she is at great risk of which of the following.
Okay. Ready.
Wait 1 second. Is it meningioma?
That's what I think.
Okay, you are right. You are choosing option very fast. Okay,
The questions are not that bad. I mean, they don't.
questions are
Yeah,
doable.
I
So
do. I feel like your word was more difficult.
your world was more toxic.
Yeah.
Truly, trust me, your
Or
world
maybe
was
because
most
we
toxic.
started with, or maybe because we started with your word. But I feel like your word question, even compared with CMS, I feel like your word was like way harder.
But thankfully we have done almost
Yeah.
everything.
Yeah.
Okay. So, in addition to bilateral acoustic neuroma, which occur in almost all individuals with neurofibromatosis type 2. Neurofibromatosis type 2 has like two eyes, 2 ears, isn't it?
2 eyes, 2 ears. Okay.
Meningioma, schwannoma, acoustic neuroma, and there is two eyes. Meningioma. Yes. Okay. Neurofibromatosis type 2, multiple tumors of the nervous system, such as intracranial valve and spinal meningioma, schwannoma, and other cranial nerves like ependymoma. Most meningioma are slow growing, and patients may therefore be asymptomatic for a prolonged period of time. If symptoms do occur, they usually include general symptoms of the CNS tumor, seizures, or more specific symptoms that are determined by the location of the tumor, paraparesis, and/or uncontrolled micturition if the tumor arises from the Fox cerebri. Other typical findings are enough to include early onset bilateral cataract, seizures, skin nodules, calf, or late spot. The clinical feature of acoustic neuroma caused by the compression of the vestibulocochlear nerve, cranial nerve 8 as a result of the tumor expanding into the internal acoustic meatus, sensory neural hearing loss, which is most common presenting symptoms, and tinnitus are due to cochlear nerve involvement, whereas dizziness, unsteady gait, disequilibrium indicate vestibular nerve involvement. Okay, let's see. So tumor with a tail, it is meningioma. This is
Mm-hmm.
meningioma. Okay. You
Mm-hmm.
want me to read this explanation
No, it's fine.
so we can just see the
Mm-hmm. The big.
tumor? Yes. Okay. You want me to read the other options?
No.
Okay. Look at this MRI. One of the question. This is Charge Weber. There is one question in the IU world relating to this Sturge, either Sturge Weber or tuberous sclerosis. One MRI I have seen in the IU world. So this is Sturge Weber. Mark Lepage. Okay, next. A 5-year-old boy is brought to the physician because of early morning headache for the past 6 months. During this period, he has had severe nausea, occasional episodes of vomiting. For the past month, he has had difficulty walking. He has had difficulty walking and intermittent double vision. He was born at term and has been healthy. He was born at term and has been healthy apart from an episode of sinusitis 8 months ago that resolved spontaneously. He is at 60 percentile for height, 50 percentile for weight, temperature is 37, pulse is 80 per minute, blood pressure 105 by 64. Examination showed normal muscle strength and 2 plus deep tendon reflex bilateral. He has broad-based gait, impaired tandem gait. Fundoscopy shows bilateral swelling of the optic disc. There is estropia of the left eye. Which of the following is the most likely diagnosis?
You scroll down. Is there any other
Yes.
answer? Mm.
So,
Mm-hmm. This one is a bit tricky. Angioplasty. Oh, it's optic glioma. Optic glioma, I don't know. Yeah, it's something in the brain. Schwann cells, schwannoma.
it is not optic glioma, isn't it?
It's not, No, it doesn't
It,
sound like no. It
it
has to
is
be.
not meningioma.
Oh, so you can take them off it. Okay.
Yes.
Okay. So it's not medulloblastoma. Don't wait. Medulla. No.
Medulloblastoma can happen. Like in there is broad-based gait and tandem gait. Isn't it look like cerebellar thing?
Yeah. Yeah,
So
go
we
with it.
can we can keep it in consideration. It is not hemangioblastoma, isn't it?
No, it's not.
Pituitary adenoma comes with headache, but it comes with other findings too,
Yeah, it's not
like
pituitary.
lactation,
It is not. I don't think it's
schwannoma.
pituitary. Sure, no. Okay, go with medulloblastoma.
Okay,
What was that?
okay.
Okay. Uh-huh.
So we have found it. Your exclusion therapy is wonderful. I know that. How you exclude things. Like I sometimes uh, I actually don't explore my things. What am I doing with what? Like after giving my answer, I actually wait to see how you answers.
Oh.
That's why but sometimes I try to hide it because you uh, pick the answer fast. So it is like I am seeing your answer and giving my answer.
I'm
Okay.
giving you answer.
Okay. First, see the MRI.
Mm-hmm.
So
Oh.
this.
Oh,
Okay.
nice,
What
nice.
solid parts? Green overlay. This is solid, and this is the cystic part. The mass in the posterior cranial fossa. Solid cystic. It what C is
Mm-hmm.
cerebellum.
Mm-hmm.
Okay.
Mm-hmm. Mm-hmm.
Just like visualize this thing. Sometimes it will help in your exam.
Mm-hmm.
So medulloblastoma is the most common malignant brain tumor in the children with a peak incidence between 3 to 5 years of age. The mass is characteristically located in the cerebellum. Medulloblastoma is characteristically located in the cerebellum. Patient typically present with symptoms of hydrocephalus or increased ICP and involvement of the cerebellar vermis, such as involvement of the cerebellar vermis, such as vomiting, morning headache, ataxia, cranial nerve dysfunction, spinal drop metastasis are found in about 40% of the case. Ependymoma are located in the posterior fossa and may also manifest with signs of hydrocephalus as well as ataxia and cranial nerve dysfunction. However, these tumors are less common than medulloblastoma, accounting for 10% of the pediatric brain tumor. Okay,
Yep.
you want me to read other options?
No.
Okay, a 54-year. You want me to read? You want me to
What?
like everything is okay?
Yeah.
Okay,
Mm-hmm.
a 54 a 54-year-old woman is brought to the physician by her brother. 54-year-old woman is brought to the physician by her father for confusion and agitation. She is unable to personally give a history. Her brother says that she has a problem with alcohol. She has a problem with alcohol use, and that has been found, and that he found an empty bottle of vodka on the counter at home. She appears disheveled. Her temperature is 37, pulse is 85, blood pressure 140 over 90. On mental status examination, to the she is confused and oriented to she is confused and oriented only to person. She recalls 0 to 3 words after 5 minutes. She cannot perform serial 7 and is unable to repeat 7 digit forward, and 5 in reverse sequence. Neurologic examination show horizontal nystagmus on the lateral cage. She has difficulty walking without assistance. Hemoglobin 11, MCB 110, platelet count 2,80,000. Which of the following is the initial test?
Are you sure all the answer choice?
Yes.
Oh, okay.
Okay.
It's either between B1 and B12. I know it cannot be glucose. You don't give glucose before B1. So I guess it's B12 since she has the MCV, but she doesn't have this.
Wait. Folate deficiency can raise the MCB, isn't it?
But there is no folate there. Where do you
Yes,
see folate?
alcoholic patient. She is
No, I'm saying
alcoholic. Sorry.
in the answer choices. Where do you see folate?
Sorry.
Oh, you meant B12? Is that what you meant?
No, I am thinking in reverse direction. Yes, it is vitamin B12. I think so.
I think it's B. Okay,
You
okay.
are thinking and B1. I am in
I
deficiency
thought
as
I'm
as it is alcoholic.
yeah because
But
I'm
if
like
it is alcoholic,
mm-hmm.
if the person is alcoholic, how MCB is high? That's the question. Alcoholic
Okay.
patient has folate deficiency. Is there anything like that?
No, there is no folate in the answer choices, but it must be because I feel like
Like in here, if it is alcoholic deficiency, like if it is alcoholic
hmm
and alcoholic patient, we should give vitamin B1 first, then the glucose. If the patient, isn't it?
yeah, that's why I thought it was. I'm thinking it's vitamin B1, but since they gave the MCV that is
MCV.
high,
Yeah.
maybe they're trying to tell you that is B12. So that's why
Yes.
I'm a bit confused between the two. But I think it's
And
B1.
I think that it is B12 now.
Oh, you think it's B12? Okay.
Now, if it is B12, like SCD can happen. Subacute combined degeneration of the spinal cord.
But they didn't give that.
He has confusion ataxia.
What is that taxia?
No ataxia. There is horizontal. The thing actually looks like B1, but the MCB tells the different history. Okay, what we will pick?
Pick whichever one. We know it's
Uh,
between those two. Or put
oh,
the attending tip.
sorry.
The tip. Maybe the tip will.
It is Barney B1 now.
Okay. Yeah, now we know. Yeah.
So why MCB? Oh, alcoholic patient can have.
Can have B12 the fish, I think also, no?
Okay, treatment with high dose IV thiamine should be initiated immediately in any patient with alcohol use disorder who presents with new onset ataxia, confusion, evidence of oculomotor dysfunction, nystagmus, Wernicke encephalopathy, indicating Wernicke encephalopathy. This condition is due to thiamine deficiency and must be treated urgently to prevent the the development and or progression of the Korsakoff syndrome. In this confused and agitated patient, administration of IV glucose must be considered as she may be hypoglycemic. However, administration before replacing thiamine in patients with thiamine deficiency can worsen the encephalopathy. Glucose metabolism would replete the already low thiamine reverse. After initiating treatment for Wernicke encephalopathy, the patient should receive benzodiazepine or chlordiazepoxide to prevent alcohol withdrawal, which is likely to occur given her history of alcohol use disorder. Okay, you want me to read the other options?
The B12.
Okay. These women's macrocytic anemia, difficulty walking and confusion must be due to vitamin B12 deficiency, which is quite common in patients with alcohol use disorder. However, the presence of nystagmus suggests Wernicke encephalopathy, which warrants a different treatment. First, to prevent irreversible sequelae, vitamin B12 and folate acid replacement should be considered in this patient once Wernicke encephalopathy has been treated.
Okay.
Okay, next.
Mhm.
A 36-year-old woman comes to the physician because of multiple episodes of headache over the past 3 months. The headache lasts entire day and are unrelenting and throbbing. During headache, she has severe nausea and is unable to work or perform daily activities. She has noticed that she becomes unusually hungry she becomes unusually hungry prior to the onset of the headache. She locks herself in the dark room, takes ibuprofen, and avoids going out until the headache subsides. However, over the past month, the headache has increased 2 to 3 times a week and become more intense. She has hypertension, treated with amlodipine. Her temperature is 37, pulse is 80 per minute, and blood pressure is 128 by 76 millimeter of mercury. Physical examination physical and neurological examination show no abnormal. Which of the following is the most appropriate therapy for long-term prevention of headache in this patient? Okay.
Ready?
Yes, it is propanol, isn't it?
You think so?
I am thinking this is a migraine headache.
It's migraine, but for long term thing is you.
Long-term prevention, what you will choose? She is not. She is not asthmatic, so a drug of choice is propanolol, isn't it? What you have picked?
Okay. I know for acute is ergo and what?
It
Ergo and
acute is like triptans, like sumatriptan,
vitamin.
rizatriptan, these drugs, and NSAID can be given. In an acetaminophen is the drug of choice. And for prolonged, like long-term prevention, we can give propanolol, we can give topiramate.
Why is it not naproxen?
Naproxen is not for prevention. Naproxen is immediate therapy.
Immediate.
Like
Okay.
you have migraine headache now, you will take naproxen and you will be okay.
So NSAID is for
NSAID
acute.
is for NSAID is for acute,
Okay.
triptans is for acute, and acetaminophen is for acute. And for the chronic, this one beta blocker. If the patient is asthmatic, you can give like other drugs. Sorry,
Mhm.
you can give other drugs like what can I say? Like tricyclic antidepressant, like anticonvulsant, like topiramate. These drugs can be used. You got my point? Okay.
Mhm.
So beta blocker, propanolol are the first line for long-term prophylaxis of migraine headache. Other drugs may be used for migraine prophylaxis include anticonvulsants such as topiramate and sodium valproate, tricyclic antidepressant, amitriptyline are second line options. Migraine prophylaxis is indicated for patients with frequent headache, frequent attack, 3 or more than 3 attacks. Migraine prophylaxis is indicated for patients with frequent attack 3 or more than 3 attacks per month. Long lasting attacks 12 or more 12 to 14 24 hours and migraine that is preceded by aura, and migraine is preceded by an aura. Other non-pharmacological therapeutic measures include lifestyle changes, exercise in moderation, avoidance of potential triggers, prolonged muscle relaxation, and biofeedback training. Beta blockers are the preferred agents for prevention of migraine headache and during pregnancy. So this is my okay. Next,
Mm-hmm.
so
So wait, are we not doing surgery today?
yes,
You said
you want to start the surgery?
yeah, because you said five. How many questions have we done here?
Okay,
I think I don't remember.
we have
I thought
done
you said
7.
yeah. I thought you said five. Do five here.
Okay, let's do surgery first. Okay, I'm stopping my sharing.
Okay. Let me share mine.
So these things are doable, isn't it?
Yeah, yeah. It's not that bad. Yeah.
Yes. We thought this would be very hard, not doable, but these things are doable. Okay. Can we take a break for 5 minutes?
Yeah.
Okay, I'm coming.
Okay. We haven't talked for 4 days, so there was a lot to talk about.
A uh, a 15-year-old boy is brought to the emergency department by his parents because of 3 hour history of severe pain. Because of 3 hour history of severe pain in the right testicle, he has not sustained any recent trauma and has not a history of serious illness. His temperature is 37, pulse is 72, blood pressure is 110 by 70. Cardiopulmonary and abdominal examination shows no abnormality. The right testicle is high in the right hemiscrotum, transverse and exquisitely tender to palpation. The left hemiscrotum is normal. Eye riding test. Ultrasonography sorry, urine analysis show no abnormal. Which of the following is the most appropriate next step in the management?
Ready?
It is torsion testis, isn't it?
Mm-hmm.
Okay.
Yes.
Yes.
Okay. So surgical exploration of the scrotum, indicated for management of testicular torsion, occurs when the testicle twists in the spermatic cord, resulting in insufficient testicular blood supply. Patients typically acute severe testicular pain, swelling, and erythema. Physical exam testicle demonstrates an abnormal light transverse, extreme tenderness to palpation, absent crematory reflex, and pain that does not improve with elevation of the scrotum, such as with epididymitis. The diagnosis is often clinical, though cases or uncertainty in evaluation begins with ultrasound, which delineates testicular size, sonographic features, blood flow, and epididymal whatever anatomy. Management requires surgery of the scrotum with the torsion of the spermatic cord, followed by bilateral orchiopexy to prevent testicular torsion. Next.
A 67-year-old man, a 67-year-old man comes to the physician because of 5 day history of chest pain, fatigue, shortness of breath, and a non-productive cough. 5 day history of chest pain, fatigue, shortness of breath, and a non-productive cough. The chest pain is exacerbated by inspiration or lying down. The chest pain is the chest pain is exacerbated by inspiration or lying down and is relieved when he leans forward. 3 weeks ago, he underwent 3 vessel coronary bypass graft. His initial post-operative course was uncomplicated. He was discharged 16 days ago. His temperature is 38.2 Fahrenheit. Pulse is 85 per minute and regular. Lungs are clear. Before friction rub is heard best over the left anterior chest. An extra of the chest should know normally an ECG is unchanged from the ECG taken on discharge. Which of the following is the most appropriate next step in the diagnosis?
Ready?
Wait. Mm, okay.
Okay, so it's echo. Echo is indicating the assessment of pericardial effusion in the setting of postoperative pericarditis. Pericarditis classically present with substernal chest pain, which is often pleuritic, worsens with lying down, and improves with leaning forward. It can occur in patients with inflammatory infectious malignant conditions such as viral infection, as lupus, tuberculosis, lymphoma, and can present as a complication of myocardial infarct and cardiac surgery. On exam, pericarditis demonstrate diastolic fissure rub, described as harsh sound heard on diastole. The condition is diagnosed clinically and supported by increased inflammatory markers. If not treated, pericarditis can lead to development of pericardial effusion, which, if large, can result in cardiac tamponade. Then echo should be performed to assess the presence of pericardial effusion, which may require pericardiocentesis if it's large. Treatment includes anti-inflammatory medications such as, NSAIDs, steroids, and colchicine. Conditions with similar presentations such as acute MIPE and aortic dissection should also be ruled out. Okay, next.
A 37-year-old woman comes to the physician for evaluation of the mole on her left cheek because uncle was recently diagnosed with elder because her uncle was recently diagnosed with widely metastatic melanoma. She has had the mole for 15 years. There have been no recent changes. Examination of the left cheek shows 0.5 centimeters smooth, dome-shaped, round, brown papule nevus with distinct symmetric border. A 4 mm movable a 4 mm smooth movable left posterior cervical lymph node is palpable. Lymph node is palpated. Which of the following is the most appropriate next step in the management?
Ready?
Okay.
Okay. So it is observation. Observation only is indicated for nevus without suspicious features concerning for malignant melanoma. Malignant melanoma is likely to be present when a skin lesion demonstrates asymmetry, irregular appearing borders, variable coloration, diameter more than 6, and rapid evolution in characteristics, as well if not a suspicion where they are greater than 1 centimeter. Irregular, non-tender, and immobile. This one is mobile. Okay. Physical exam. This patient exhibits non-suspicious nevus of the legitic and non-suspicious lymph node. Is not, where was that? CNA. Excisional biopsy of the nevus with rim of normal skin or incisional biopsy of the nevus are all potential option for evaluation of a suspicious skin lesion. This patient present with never start does not have a suspicious feature for for melanoma. Any lesion with features suggested of melanoma should undergo excisional biopsy with assessment of margins and deep and depth of dermal invasion. Malignant melanoma has the ability to rapidly invade. Okay. What's the difference between excisional and incisional biopsy? Do you know?
Excisional means like if your nevus is 4 millimeter, we will totally excise the whole thing. And incisional means like you are giving incision and you are taking part of it, as far I know.
Okay.
Like in the, if it is huge ulcer, like if it is huge ulcer, then we can do incisional. But if it is smaller and easily we can easily extract all the tumors, then it may
Okay.
be excisional. Okay, may not be correct.
I like the explanation. I'll take it.
Okay, I am talking through my literature. Okay, a 4-year-old boy. A 4-year-old boy is brought to the a 4-year-old boy is brought to the physician because of pain and burning of her right feet after playing in sandbox. Although he insists that something is in his eye, he continues to rub it, and no foreign body is apparent. He also states that his vision is blurry. In his right eye, there is moderate conjunctival injection with marked tearing and photophobia. The pupils are equal, round, and reactive to light and accumulation. Fundoscopy examination show no abnormality. Which of the following is the most appropriate next step in the diagnosis?
Hmm. Ready?
Yes.
Conjunctival instillation of fluorescein is indicated for evaluation of a potential corneal abrasion or residual corneal or conjunctival foreign body. Residual cornea. Okay. A corneal abrasion is one of the most common eye injuries and occurs secondary to disruption of the top layer of the cornea, the corneal epithelium, which can occur spontaneously or uh, from trauma from a foreign body like contact lens and workplace debris. Patients typically present with eye discomfort, blurry vision, photophobia, difficulty opening the eye, foreign body sensation. Physical exam demonstrates excess lacrimation, conjunctival redness, decreased visual acuity, light sensitivity. Fluorescein staining is indicated to assess for corneal injury. Fluorescein passes over the intact corneal tissue but is trapped in epithelial defects, which are easily visualized under black light. Treatment requires removal of the residual body, copious irrigation with saline, administration of cycloplegic drops, and topical antibiotic if a large abrasion is present.
What is the
Mm,
key point here? How we can diagnose?
um, I guess they're saying that foreign body, whatever, is a key point. I don't know if for cornea, foreign body sensation is a key point for corneal abrasion. Sorry. Yeah, because he said he feels something in the eye even if you don't really see anything in the eye. And they also say conjunctival injection and photophobia. Yeah.
Okay. Conjunctival injection photophobia.
But I mean, you can see conjunctival injection in other things, but I guess photophobia will be, yeah, will be
Okay.
okay here. Next.
A previously healthy 42-year-old woman has the abrupt onset of severe headache, followed several hours later by lethargy and coma. On admission to the hospital, she is unresponsive and has nuchal rigidity, pupillary responses and pupillary response and corneal and oculocephalic reflexes are intact. She dies the following day. An autopsy is most likely to show which of the following.
Ready?
Yes.
Okay, so it's fresh subarachnoid hemorrhage at the base of the brain. Fresh, most likely cause of this patient acute onset severe headache. Oh, he had headache. With subsequent, I guess, nuchal rigidity, meningitis commended. Rupture intracerebral aneurysm is the most common cause of non-traumatic SAH, subarachnoid hemorrhage, especially in previous healthy patients. Circular intracerebral aneurysm typically occurs at bifurcation of the sickle of Willis, the base of the brain, most commonly at the site of the ACOM. Patients may present with acute severe headaches, stupor, coma in severe cases. In physical exam, nuchal rigidity is common finding, secondary to meningeal irritation from blood products in the subarachnoid space. CT scan demonstrates hyperdense blood products in the cerebral sulci and basal system if performed within 6 hours of onset. As the blood products circulate within the subarachnoid space, communicating an obstructive hydrocephalus can result, which leads to increased intracranial pressure, potential herniation, comma, and death. It's not, what was I confused about? The hemorrhage in the pons and midbrain is most commonly associated with hypertension, typically present with decreased level of consciousness, stupor, comma, locked-in syndrome, pons, Lundteg syndrome. Yeah. Along with quadriplegia, cranial nerve palsy, and change Stokes respiration. Okay, next.
Okay. A hospitalized 62-year-old woman has rash rash over her lower extremity that develops 2 days after she underwent emergent left-sided cardiac catheterization and subsequently angioplasty and stent placement to the left LAD. There were no intraoperative complications. The patient was admitted because of poor history of chest pain on admission. Initial ECG 3 centimeter ST elevation in V2 to V4. Her temperature is 36, pulse 98, respiration 14 per minute, blood pressure 138/78. A photograph of the rash is given. With the posterior tibial pulses are palpable bilaterally. Which of the following is the most likely cause of this patient rash?
Between D and E, systemic vasculitis. Mm, mm, mm.
Ready?
I feel like it's D. Okay,
Why?
right. I don't know. I'm like it's between D and E. Okay, fine. Let's just go. Ah, one even close. Aortic atheroembolism, also known as cholesterol embolization syndrome, occurs secondary to embolization of atherosclerotic plaque contents like cholesterol crystals from a large artery, aorta, to distal small arteries and arteriole. This results in occlusion of the distal arterial vasculature with small cholesterol emboli, which induces a localized inflammatory response and end organ damage. Hematologic manifestation of these phenomena are localized petechiae, livedo reticularis, Bluetooth syndrome. Risk factors for cholesterol embolization include trauma and intervention procedure that increase the risk of damage and dislodgement of atherosclerotic parts, such as cardiac catheterization, damage to the atherosclerotic parts of the thoracic and abdominal aorta via femoral artery approach. Okay. Cholesterol emboli can also involve other organs, resulting in renal failure, colonic ischemia, cerebrovascular accident, and skeletal muscle ischemia. It's not systemic vasculitis reserved to generalized inflammation of the blood vessel. There are a variety of vasculitis which range in clinical presentation and involvement of large, medium, or small vessels. It will not typically present a Bluetooth syndrome and typical and localized petechia. Okay. Thrombocytopenia-induced capillary bleeding includes petechia, ecchymosis, mucosal bleeding. Okay. Along with persistent oozy. It will not likely be localized to the lower extremity. Okay. Next.
Okay. Just a 60-year-old woman has left shoulder and arm pain, for 2 weeks. She has smoked 2 packs of cigarette daily for 35 years. Examination shows a fixed dilated pupil and ptosis on the left. Eggs of the chest are shown. Which of the following is the most likely diagnosis?
Hmm.
Ready?
No, give me a second. My mama. TB. I guess it's here, but no, it's not mesothelioma. It doesn't show like that. Bronchogenic carcinoma. Oh, is it bronchogenic carcinoma? Doesn't make sense. Bronchogenic will be in the bronchi. How did you find it so quick?
What I did wrong. I have seen the X-ray. I thought it is bilateral
Oh,
hilar lymphadenopathy, but it is not the answer.
okay, so it's not sarcoidosis.
No.
TB, no, it will be like the things. It's not that. The only thing that left is bronchogenic carcinoma, I guess. Okay, let's see. Okay, it's bronchogenic carcinoma. I thought bronchogenic was in the bronchi. Bronchogenic carcinoma is the leading cause of cancer-related death in the U.S. It's typically divided into two classifications: small cell, what? Small cell and non-small cell carcinoma. It commonly presents as cough, weight loss, hemoptysis, and potential signs of bronchial obstruction, such as wheezing. If the carcinoma is located within the lung apex referred to pancreas tumor, it can infiltrate multiple adjacent structures, such as the superior vena cava, the subclavian vessels, sympathetic chain, recurrent allegiant nerve, and brachial plexus. This can result in presenting features of Horner syndrome, ipsilateral shoulder and upper extremity pain, hoarseness. If the pancreas tumor involves the right lung apex, superior vena cava syndrome can occur, which manifests with bilateral upper extremity and facial swelling, erythema, and vascular congestion caused by insufficient venous drainage, mass effect, or vessel invasion. Pancreas typically presents as a consolidated, rounded mass in the lung apex on chest X-ray and CT scan. Because this is new. I thought bronchogenic was a type of cancer on its own, but I guess yeah, that's new to me. Okay,
Where is the tumor?
it's right here. Like I can see, you can see it, but it's just I. I was
Sorry,
expecting, I was expecting pancos like there would, one of the options would be like pancos tumor.
pancreas tumor
Yeah,
in the left upper.
left upper.
Okay.
Now, once you see the tumor, you know what's happening because he has stenosis and whatever, But it's just none of these. Like mesothelioma is the pleural space. Sarcoidosis is the bilateral, and it should be here, but the sarcoidosis is usually here. You will see the two big things, so it's not that. And thymoma is like you don't, yeah, you don't need an X-ray to see thymoma. And TB is usually the cavities with the water inside, whatever the cavities with the fungi inside, whatever you've seen it before. So the only thing that's left is the bronchogenic. But
That's it.
bronchogenic, yeah, but the bronchogenic is usually inside the bronch, like it will show you inside the bronchi. That's why I was confused. But I guess if you eliminate everything else, I guess that's
That is good actually. True. Next, a 62-year-old man comes to the emergency. A 62-year-old man comes to the emergency department because of swelling and discomfort. Because of swelling and discomfort of the left foot that began after digging in his garden 2 weeks ago. The patient has there is no history of trauma. There is no history of trauma. He has type 2 diabetes mellitus with oral hypoglycemic agent. His temperature is 37.2 pounds, 74 per minute, blood pressure 150 over 92. Examination shows markedly swollen, warm, erythematous, markedly swollen, warm, erythematous left foot. There is no tenderness to palpation of the foot. Pedal pulses or palpable sensation to the light touch. Sensation to the light touch is intact. Proprioception is decreased. Range of motion of the left ankle is from 20 degrees of flexion to 30 degree of plantar flexion. 20 degree of dorsiflexion, 30 degree plantar flexion. Movement is not painful. Lab show hemoglobin 14.5, leukocyte 11,000, PSF 25, serum glucose 124 extra. The left feet show fragmentation and destruction of the mid-tarsal joint. Fragmentation and destruction of the mid-tarsal joint and lateral subluxation of the forefeet. Which of the following is the most likely underlying mechanism of this patient?
ready.
Is it rheumatoid arthritis?
I don't think so. ESR is. Let me see. Wait, let me check ESR.
Yes, it is.
Well, it's high, huh? But I mean, the normal is 0 to
Markedly swollen, warm, erythematous left foot. Hmm. You are
yeah.
thinking about gout.
No, I was thinking, um, the diabetes one, but it doesn't make.
Osteomyelitis,
No, the diabetes one,
immune, uh,
the
A
one where
option. Oh, loss of afferent sensory nerve function.
but maybe not.
May happen. You are right, maybe. Okay, let's see.
Oh, it's the same thing. Yeah, it's the diabetes one. I don't remember the name. Loss of afferent sensory nerve function occurs in the setting of peripheral neuropathy, which is a risk factor for the development of Charcot. That's the one, the Charcot arthropathy. Okay, risk factor for diminished peripheral sensation, neuropathy include diabetes, alcohol use disorder, end-stage renal disease, vinca alkaloid chemotherapeutic drugs, syringomyelia, neurosyphilis. Oh, there's a lot of them. Spinal cord injury, MS, vasculitis, and inflammatory disorder. Charcot arthropathy occurs secondary to an initial inflammatory response from a minor injury, which is not appropriately identified by the patient because of underlying afferent sensory nerve dysfunction. This can result in progressive osteolysis from most commonly on the foot, which can present with destruction, fragmentation, erosion, and misalignment of bony articulations. In the acute phase, Charcot arthropathy presents as swollen right foot. Evaluation begins with X-rays and CT scan. We may require MRI to assess the extent of the disease and complication of confounding diagnosis such as osteomyelitis. Okay,
Okay.
next.
A 47-year-old woman with breast cancer has sudden onset of confusion and lethargy. Fundoscopy examination shows papilledema. CT scan of the head shows cerebellar metastasis. Which of the following is the most appropriate next step in the management?
Ready?
So, yes.
Yeah. So it is steroid therapy. Steroid therapy most appropriate treatment for patients presenting with increased intracranial pressure related to underlying cranial metastasis. The most common intracranial tumor is a metastatic lesion from extracranial primary malignancy. Cerebellum is most common location of metastasis along with the great white matter junction in the supratentorial brain. Cerebellar metastatic present with headache and symptoms of cerebral dysfunctions, such as gait disturbance, limb discoordination, dizziness. Metastases to the brain are associated with significant vasogenic edema. This edema can lead to abnormal enlargement of the cerebellum, which can impress upon the foreventricle and foramina of Buschke. This can result in development of obstructive hydrocephalus and increase in intracranial pressure. Increased ICP presents non-specific tendon alterment stop, whatever we know. Papilledema refers to optic due to swellings in whatever, and is secondary to increase intracranial pressure. The administration of IV steroids assists in reducing the metastasis associated vasogenic edema, limiting its mass effect and risk for development of obstructive hydrocephalus. Next.
Okay. A 57-year-old woman is brought to the emergency department after being found comatose during the past 3 days she has been lethargic and some somnolent. She has been lethargic and somnolent, but her but she has not had focal neurological sign. 12 years ago, she has stage 3 carcinoma of the right breast treated with modified radical mastectomy and adjuvant chemotherapy. 2 weeks ago, the patient underwent a course of radiation therapy to the lumbar spine and the iliac crest for painful. Sorry, 8 months ago, pulmonary metastasis was diagnosed that has responded well to the cytotoxic chemotherapy. 2 weeks ago, the patient underwent a course of radiation therapy to the lumbar spine and the iliac crest for painful bony metastasis. Which of the following is the most likely cause of this patient's symptom? Mm,
Ready?
Oh, wait, one sec. Uh, okay,
So it is hypercalcemia. Oh, did not see that one. Hypercalcemic crisis. Hypercalcemic crisis secondary to malignancy associated hypercalcemia is the most likely cause of the patient's symptoms. Acute hypercalcemia can present as a broad spectrum of symptoms and can be life threatening because of its effect on neuronal conduction, the cardiac action potential, kidney function, and volume status. It commonly presents as constipation, lethargy, weakness, altered mental status. It can result in short QT interval and nephrogenic DI, leading to significant dehydration. A potential cause of severe hypercalcemic crisis is malignancy associated hypercalcemia, which can be secondary to the humoral secretion of PTH, PTH-related peptides, squamous cell carcinoma of the lung, or from direct invasion of and lytic lesion of the bone from osseous metastasis like breast cancer. Treatment emphasizes preventing end-stage kidney disease, promoting renal excretion of calcium, reducing intestinal absorption of calcium, inhibiting bone destruction, and if necessary, replacement therapy with dialysis. Treatment, therefore, begins with infusion of normal saline to restore intravascular volume and dilute serum calcium, followed by administration of osteoclast inhibitors such as bisphosphonates and possible calcitonin if further medication are required to decrease blah blah blah. How do we know here that she had? They didn't say anything about. Okay, so, and it's not.
hypercalcemia.
Yeah, it doesn't say she had constipation or anything. Adverse reaction to cytotoxic chemo can result in hypocalcemia, such as in the setting of tumor lysis syndrome. Tumor lysis syndrome commonly occurs following chemo initiation for leukemia and lymphoma. The abrupt destruction of large number of tumor cells results in interstitial and serum release of the contents, manifesting as hyperphosphatemia, hypocalcemia, hyperkalemia, hyperuricemia. The toxic chemo is not typically associated with hypercalcemia. It still doesn't make any sense. Okay, I guess we'll go with that. Because here they're only talking about the treatment she received, the chemo, and then the whatever, the chemo
And
for the
then he gone for radiotherapy.
yeah, the radiotherapy for the bone, and then the chemo for the metastasis to the whatever lungs. So I don't know. I guess the key was that it keeps metastasizing. So I don't know.
Okay.
Oh, next.
Okay, can we take a 5 minute break?
Yeah, sure.
Okay.
Okay.
Okay. Question 11. A 57-year-old woman who has tuberculosis for many years come to emergency department because of why hemoptysis that has progressed over the past 6 hours. She is slender but not emaciated except the chest. Shows a 3 centimeter cavity in the left, a 3 centimeter cavity in the left upper lobe of the lung, and around 2 centimeter mass in its lumen. Um, which of the following is the most likely cause of hemoptysis? Mass in the lumen. Upper
Ready?
One sec.
Mm-hmm.
Okay.
Okay, so it's aspergilloma. Most common presentation of pulmonary aspergillosis resulting from infection by the Aspergillus species, which is characterized by septate hyphae with acute angle branching. Pulmonary aspergillosis can result in many clinical presentations such as aspergilloma, allergic bronchopulmonary aspergillosis, APA, and chronic necrotizing aspergillosis, and airway invasive or angioinvasive aspergillosis. Aspergilloma is the formation of fungal masses arise within existing cavitary lesions of the lungs, such as those caused by previous infections like TB, bullae, emphysematous blebs, or from cavitary squamous cell lung carcinoma. Patients typically present with persistent, sometimes bloody cough with a history of prior cavitary lung disease. Chest X-ray should be obtained, which will demonstrate a round solid nodule or mass within a larger lung cavity. The location of the cavity and fungal mass varies based on the location of the cavitary disease, with an apical predominance following TB and varied location in the setting of squamous cell carcinoma and emphysematous bullae. Next.
A 65-year-old man is brought to the emergency department 1 hour after an episode of syncope. He has a 1 day history of back pain. He has a 1 day history of back pain that radiates to his groin. He has hypertension, chronic back pain, hypercholesterol. He has hypertension, chronic back pain, hypercholesterol. His medications are hydrochlorothiazide. His medications are hydrochlorothiazide, lisinopril, simvastatin, and ibuprofen. He has smoked 1 pack of cigarettes daily for 40 years. His temperature is 36.6 degrees Celsius. Pulse is 124 per minute. Respiration 22 per minute. Blood pressure 92 by 54. Blood pressure 92 by 54. Pulse oximetry of the room here. Oxygen show 90. Show oxygen saturation 97%. Abdominal examination show diffuse tenderness with no guarding. And rebound. A pulsatile abdominal mass is palpated in the supraumbilical region. Uh, Examination of the back shows no abnormality. Which of the following is the most appropriate next step in the management? Ready? Is it triple A? Abdominal aortic aneurysm.
Yeah, but so do you do ultrasound? I guess. Guess okay. Next, let's see. Yeah, ultrasound. I wonder why it's not peritoneal device since he has low blood pressure. Okay, bedside ultrasound is the most appropriate next step for diagnosis of potentially ruptured triple A. Triple A most commonly occur in the infrarenal abdominal aorta, secondary to relative insufficient blood supply from the vasa vasorum. This results in increased susceptibility to aneurysm formation. AAA are associated with atherosclerosis, increased age, male sex, family history, tobacco use. They can present as pulsatile abdominal match, which may be difficult to palpate in patients with obesity. The USPF, whatever, recommends asymptomatic screening of AAA with ultrasound in men 65 to 75 who have ever smoked. Findings that raise suspicion for rupture typically include acute sharp tearing abdominal or back pain with features of hemorrhagic shock like tachycardia and hypotension. Yeah. Okay, bedside ultrasound is the quickest option to evaluate the abdominal aorta and permit delineation of AAA size. May show evidence of rupture or dissection as well. Definitive management includes endovascular or open surgical repair of the abdominal aorta. It's not CT scan of the abdomen and pelvis with contrast is not indicated in situation concerning for AAA rupture when hemorrhagic shock is present. Obtaining CT scan will require an inappropriate amount of time, which will delay definitive diagnosis and management, and risk further hemodynamic decompensation. It's not a peritoneal lavage involves aspiration of peritoneal contents, infusing sterile saline into the peritoneal cavity, and analyzing the effluent. If blood, food particles, bile, bilirubin, amylase, or alphals are found, exploratory appanotomy is indicated, as the presence of these findings suggests hollow or solid viscous injury. It's not digital subtraction arteriography is a fluoroscopy technique used for visualization of blood vessels during catheter angiography. This technique is used for a variety of endovascular techniques, including arterial stenting, geoplasty embolization, thrombectomy, and endovascular aneurysm repair. Okay.
Next, a 57-year-old woman with metastatic cancer of the sigmoid colon is admitted to the hospital because of 2-day history of progressive swelling and pain of her right arm. Progressive swelling and pain of her right arm. 10 days ago, she underwent partial, 10 days ago, she underwent partial resection of the liver and placement of right subclavian venous port. She recently took no medication examination today shows a swollen tender right forearm and hand. Venous duplex ultrasonography shows thrombosis of the right axillary. Venous duplex ultrasonography shows thrombosis of the right axillary and subclavian veins. The port and the catheter are removed. IV unfractionalized therapy is begun after 2 days of unfractionalized heparin therapy. The patient pain has decreased. Lab studies on admission and after 2 days after mm, unfractionalized heparin therapy. On admission, hemoglobin is 9.8, 2 days after 9.6. Hematocrit 27, 2 days after 28, 27. Leukocyte 8,900 and it becomes 12,600. Platelet count 2,60,000 and it becomes 61,000. PT is 12 and 13 and PTT is 32 and 87. So PTT is high, low platelet. Which of the following is the next step in the management?
Ready?
Yes.
So it is for discontinuation of heparin. Discontinuation of heparin is the first step in management of heat. Heat typically occurs between 5 to 10 days, and even if here is 2 days, after initiation of heparin therapy. It results from the development of IgG antibodies against the complex of heparin and platelet 4 factor, platelet factor 4. The antibody heparin platelet leads to activation of platelet, which can cause thrombosis and consumption of platelet. The abnormal activation and consumption result in progressive decreased platelet count, which typically is like 50% of their initial level. Treatment requires cessation of all heparin products and fractionated and low molecular. The patient should be transitioned to direct thrombin inhibitor or direct 10A inhibitor to ensure adequate anticoagulation without worsening of thrombocytopenia. It's not DNE. Platelet transfusion contraindication is a contraindication in patients with AIDS, as the catalytic antibody complex results in activation of platelet, which leads to further consumption and thrombosis. Warfarin will not be appropriate in the early stages of heat, as it can result in worsening of thrombosis because of transient hypercoagulability from initial decreased concentration of CNS, and can increase the risk of gangrene of the extremities. Okay, next.
An 82-year-old man comes to the emergency department because of 2-day history of History of extreme difficulty voiding and urinary incontinence. Extreme difficulty voiding and urinary incontinence. She has seasonal rhinitis. She has seasonal rhinitis, hypertension, congestive heart failure. Medication include diphenhydramine, isosorbate dinitrate, metoprolol, terazosin, lisinopril. Vital signs are within the normal limit. Physical examination show moderately enlarged, non-tender, moderately enlarged, non-tender prostate. No masses are palpated. His post-viral residual volume is 490 ml. Which of the following medication is the most likely contributing? Which of the following medication is the most likely contributing to his urinary symptoms?
What are those ozine again?
So,
Alpha agonists or alpha blockers?
sorry,
Terazozine. The terazozine,
alpha
what is
blocker.
alpha blocker? Is it like alpha 1 blocker? Alpha 1 blocker.
Is it?
Ah.
Are you thinking this is the answer?
You say it's alpha 1 blocker.
Yes.
Oh, then it cannot be alpha blocker. Alpha 1. Yeah, it cannot be. Okay. Ready?
Yes. Isn't it diphenhydramine, fast generation, and histamine?
Yeah. Um, Diphenhydramine, first generation antihistamine blocking agent that is commonly used to treat allergies, insomnia, motion blur. Many adverse effects than diphenhydramine as a result of CNS H1 receptor blockade, anticholinergic, and anti alpha 1 blocker. So alpha 1 blocker. This leads to constellation of symptoms such as dry mouth, urinary detention, constipation, hallucination, delirium, blah blah blah. Muscarinic type 3 receptors stimulate the contraction of smooth muscles in the urinary bladder wall. Anticholinergic adverse effect of the diphenhydramine antagonize this action, resulting in impaired urinary bladder contraction, which leads to urinary retention. In addition to catheterization to prevent damage to the bladder and kidneys, treatment requires cessation of the offending drug and substitution with second generation alpha 1 receptor blocking, such as loratadine, which does not produce anticholinergic adverse effect. Okay.
Next.
Mm-hmm.
Okay. This is calculated. Okay, 55-year-old man has had heel pain. A 55-year-old man has had heel pain and associated limp for a month. He works as a police officer and walks most of the day. The pain is almost severe when he stands up and walks after lying or sitting. Palpation of the medial plantar surface of the heel. Medial plantar surface increases pain. An X-ray of the heel is shown. Which of the following is most likely diagnosis? Okay.
Ready?
Yes.
Okay. Plantar fasciitis results from inflammation of the plantar aponeurosis. Okay, commonly at its origin on the plantar surface of the calcaneus. Presents as sharp pain along the medial plantar heel, which typically is worse during ambulation after sitting for a long or lying down, and then or after prolonged standing. These factors include obesity, weight bearing, endurance activities such as running or dancing, which can result in chronic micro tears of the plantar fascia, resulting in recurrent inflammation and periosteitis. It may, it may be associated with plantar calcaneal and tesophyte formation, ill-spur. Treatment should begin with non-operative management, including pain control, splinting, stretching, therapy specific for plantar fascia. Next.
10 minutes after transfusion of packed red blood cells begin, a 62-year-old woman has chest pain, shortness of breath, and the feeling of impending doom. The transfusion is stopped immediately. Her temperature is 101, pulse 90, respiration 20, blood pressure 110 by 80. Examination shows no other abnormal. So following is the most appropriate next step in the management.
Ready?
One sec. Yes, ready.
Okay. So is direct comes test. Direct comes test is necessary for evaluation of suspected hemolytic transfusion reaction. Transfusion reaction can range from mild itching, fever, mild rash, to severe hemolysis and anaphylaxis. Most reactions are mild and may not necessitate cessation of transfusion. An acute febrile transfusion reaction, febrile non-hemolytic reaction, occurs because of the presence of preformed antibodies to donor leukocyte antigen and occasionally from cytokines in the plasma component of the transfused sample. Febrile non-hemolytic transfusion reaction range from mild fever, minimal additional symptoms, to severe high fevers, rigor, myalgia, nausea. Treatment consists of purging the transfusion to rule out ABO incompatibility by performing the direct Combs test. The Combs test entails testing for the presence of antibody on the recipient red blood cells, ABO incompatibility. Any positive will confirm the acute hemolytic transfusion reaction instead of the febrile non whatever. Distinguishing the two is important as acute hemolytic transfusion can be life-threatening, leading to massive hemolysis, renal disease, disseminated intravascular. Blah, blah, blah. Next, next.
Yes. What is Duffy antigen? The option D.
Duffy antigen test assesses for the presence of Duffy antigen on the recipient red blood cells. The Duffy antigen is a glycoprotein that can be expressed on the surface as RBCs. Antibodies to the Duffy antigen can cause hemolytic transfusion reaction, although this is less common than ABO incompatibility.
Next. A 50-year-old man with chronic constipation has had anal pain after each bowel movement for 2 weeks. Anal pain after each bowel movement for 2 weeks. He has had noted a small amount of he has had noted a small amount of bright red blood on the toilet tissue. Patient is relieved by seized blood between bowel movements. Which of the following is the most likely cause of this patient's symptoms?
Ready?
Yes.
So it's anal fissure. Anal fissure appears in the superficial anal mucosa below the dentate line, typically along the posterior border. Because of the location below the dentate line with somatic blah, 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 they result in significant pain during defecation and are associated with bright red blood on toilet paper. Common initial common initiation factor for the development of anal fissure is a history of chronic constipation resulting in passage of hard stool, which can cause trauma to the anal mucosa. While some anal fissures self-resolve, persistent anal fissure can result in anal spasm and increase sphincter tone on examination. Initial management for persistent symptomatic anesthesia includes administration of stool softener, sit bath, topical analgesics, and topical vasodilators. The goal of this combination therapy is to relieve pain, allow for anal sphincter relaxation, and reduce traumatic passage of stool to the anal canal. It's not thrombus external hemorrhoid presents as acute severe anal pain with an associated tender or swollen bulging blue purple colored nodule. Treatment includes topical analgesics and corticosteroid, but if severe, may require surgical excision. Okay, for immediate pain relief. Next.
Next, 36 hours after hospitalization for multiple fracture sustained in a motor vehicle collision. A 47-year-old man develops double vision, confusion, drowsiness. Examination now shows scattered petechiae over proportion of the trunk. Lab shows on admission hematocrit is 50% now, 30% platelet count more than 1,60,000 now, more than 1,60,000. Serum alcohol 235, less than 8 X-ray of the chest, and ECG admission show no abnormality, X-ray of the chest show diffuse fatty infiltrate. Which of the following is most likely diagnosis? Is it fat embolism?
Don't know yet. Diffuse patchy infiltrate. Hmm. Why do you say? Oh, because of the petechia. Hmm. But why the double vision and the confusion? And drowsiness.
It is not MI, isn't it?
Am I? No, I don't think so. Am I? No. Um, Double vision
Or you are thinking of delirium tremens. He may be alcoholic, like alcohol withdrawal delirium tremens.
what are the tremors?
Delirium tremens.
Yeah, but delirium tremens is delirium and tremors, but they are not tremors. Um, I'm between, what should you say? It's just patchy infiltrate. Patchy infiltrate and ECG was fine, so it cannot be MI. So it's between aspiration pneumonia and fat embolism. Fat embolism will go with the petechia, makes sense. Aspiration pneumonia will go with the diffuse patchy infiltrates. Now we have to find something that differentiate both. Hematocrit is low now.
There is no fever, so there it is not
It's not
pneumonitis.
pneumonitis. Okay, fat embolism it is then. Okay, let's see. Ready?
Yes,
Yes, fat embolism is typically associated with lumbar fractures resulting from fat macroglobule embolization to the pulmonary and systemic circulation. Less common causes of fat embolism include liposuction, bone marrow biopsy transplant, and massive soft tissue injuries or burns. Patients are often asymptomatic, but if severe fat embolism can present with the classic triad of hypoxemia, petechial rash, and neurologic derangements. Pulmonary dysfunction varies depending on the severity of the emboli, presenting as tachypnea, tachycardia, dyspnea, and hypoxemia. Cerebral manifestation may include altered mental status, visual disturbance, cranial nerve deficits, stupor, seizure, coma. Skin manifestations include non-palpable petechial rash involving the conjunctiva, the neck, the axilla, chest. If the degree and distribution of the emboli is severe, there is potential for multi-organ dysfunction. Diagnostic imaging of the lung may show bilateral patchy consolidation. which can often resemble acute ARDS. Treatment is supported involving maintenance of adequate oxygen in intravascular volume. It's not aspiration pneumonitis refers to acute chemical injury of the pulmonary alveolar and airways caused by inhalation of gastric content. Patients at high risk for aspiration include those with impaired airway protection, cough mechanism, frequent forcing, and abnormal pharyngeal or airway anatomy. Okay, next.
Okay. A 57-year-old woman has decreased urine output 15 ml per hour 2 hours after undergoing radical hysterectomy for endometrial cancer. The urine is dark yellow. The operation lasts for 4 hours. Her blood pressure is decreased to 70 by 50 millimeter of mercury. Um, and briefly, during operation, she received 3 liters of lactate ringer solution, 2 units of pancreas cell intraoperatively. She has no history of diabetes mellitus, chronic renal insufficiency. She has no history of diabetes mellitus, chronic renal insufficiency. Her, her pulse is 110 per minute, respiration 14 per minute, and blood pressure now 100 by 70 millimeter mercury. The lungs are clear to auscultation. There is no abdominal discharge of the following. The most likely cause of falling. Hmm.
Hmm. Medical hysterectomy. And then it's dark yellow. Hmm. Between B and E, decreased renal blood flow and ureteral obstruction. Dark and yellow. That's no
Okay.
chronic. Okay. Ready?
Yes.
Okay. Ah, it's decreased renal blood flow. What am I? Okay. Decreased renal blood flow resulting in prerenal azotemia is the most likely cause of the patient's post-surgical oliguria. Normal urine output ranges from like, I don't know, zero point 0.5 to 2 cc/kgh per hour. Renal azotemia refers to an acute kidney injury secondary to insufficient renal blood flow in states of hypoperfusion will result in decreased GFR. This can occur in the setting of hypovolemia hypotension, including transient intraoperative hypotension. In response to the decreased renal blood flow, renin and angiotensin are upregulated, which stimulates increased absorption of sodium in the proximal. In the PCT, the decreased GFR results in decreased tubular flow rate, which consequently leads to increased urea nitrogen reabsorption and reduced urine volume because of the increased reabsorption of solute and water. Treatment of renal azotemia requires treatment of the underlying cause of reduced renal blood flow, often requiring the administration of resuscitative IV fluids. If untreated, this can progress to worsening acute kidney injury and possible intrinsic end-stage kidney disease. It is not E. Obstruction of bladder drainage and ureteral obstruction, if involving bilateral ureters, can result in post-renal azotemia from impaired urinary drainage. Okay, this typically presents as anuria because of the obstruction of urinary flow. As well, the patient had an episode of transient intraoperative hypotension, making urinary tract obstruction less likely. Okay, next.
Okay. Question number 20. A 38-year-old man 38-year-old man who has been receiving corticosteroid for asthma has and emergency appendectomy for a ruptured appendix. In the recovery room, he becomes confused and febrile. His blood pressure is 85 by 60, pulse is 130 per minute. Abdominal ABG gas are normal. His blood pressure does not respond to infusion of 1 liter of lactated ringer solution. Which of the following is the most appropriate next step in the management?
Ready?
1 sec. Okay.
Okay, so is administration of hydrocortisone. Um, is indicated in the management of acute adrenal insufficiency. The chronic use of exogenous steroid results in decreased production of ACTH from pituitary gland. This leads to atrophy of the bilateral adrenal glands and resultant diminished native production of steroids. In the event of physiologic stressor like surgery, trauma, infection, but this physiologic demand for steroid increases, but is not met because of the patient chronic adrenal atrophy. This results in the onset of acute relative adrenal insufficiency, which presents a hypoglycemia, altered mental status, hyponatremia, tachycardia, and abdominal vasodilation.
Okay.
Okay, including fluids and pressure refractory hypotension. While difficult to diagnose because of its non-specific presentation, acute adrenal crisis should be considered in the differential of any patient presenting with circulatory collapse. Treatment requires the administration of IV steroids to improve systemic vascular resistance. Next.
Okay. Can I stop here?
Yes, we can.
Okay.
Okay. See you tomorrow.
Okay. Bye.